or Tuesday for those who are coming on Tuesdays. Okay, we'll start by saying, why do we need IVs? Why is it important to have an IV access? Why can't we just give the medication by mouth or by another route? I'll be skipping this. We have different type of IVs. IV can come in the form of peripheral access, which is the regular IVs we're going to practice in the lab on Monday and Tuesdays. We can have a central line device. And in this picture, if you can see, there's a double lumen central line device. And then we can have unimplanted ports. So you see two different type of ports here. Or we can have a PICC line. In this specific picture, you see the neonatal or the pediatric PICC line. And I know this is really, really small. So this is probably like a 3 French PICC line here, or even smaller. Yeah, 3 French PICC line. And I can tell that this is pediatric, not because it's small, but because the stat block that is on it. So stat block is used to ensure that the PICC line is not pulled out. And how I know it's pediatric, when I look at the stat block, this white dressing kit here, it looked like a bear. So that's how I know it's pediatric. And the smaller one are usually single lumen. If we are starting IV therapy, of course, we have to start by knowing the standards of practice of our institution. Not everyone can insert an IV at institution, even though you may have nurses who have the ability to do so. Um, if you work with LVN, maybe it's best to check if they can insert an IV. Some facilities, the LVN has the ability to insert their IV, they're IV certified, but they have a limitation at that particular institution as to what they can do and not do in terms of IV therapy. So it's always best to keep abreast the policies of that facility. In addition to competency, um, just because I am competent, it doesn't mean I am able. And that needs to be clear because we have nurses who are IV certified, but however, they're not the best at IV. They haven't been practicing the skills. So they might always defer to somebody else when it comes to inserting IVs. Some facilities even go as far as having an IV team in the facility. So facilities who have like really robust infrastructure, or those who choose to invest the money in creating a team specific to start an IV, may have IV team in place where every time you need an IV, you will call the IV team rather than the individual nurses trying to start that IV on the floor, especially if it's a heart stick patient. Now, what I'm used to, unit, especially ICU unit, can form their own shared governance team or their own IV team where they just don't insert IV, but they're equally trained to insert PICC line. So the PICC line nurse is not necessarily coming from the PICC line department in the hospital, but you have unit-based PICC line team themselves. So it's even more effective because if we have, for us with our unit-based PICC line team, we can get the PICC lines in faster than if we were to call the hospital PICC line team, because the hospital PICC line team had to go to all the hospital. They have a schedule. They have to attend to all the PICC line needs in the facility, as opposed to your team is attending. What is our responsibility? Your PICC line needs as a nurse in IV therapy. Why do you Okay, what is our responsibility as a nurse in IV therapy? Why do you why do we use IV therapy? What can we use IV therapy for? I think before we start on IV therapy, and I'm gonna go to the next slide for this. we need to make sure that no one is getting injured because handling needles can lead to needle stick, right? So we have exposure to injury for the person who is inserting the IV, as well as the person who is getting the IV. The patient can be at risk. You can have a chemical exposure if you're given a chemotherapy or a biologic drug, for instance. You have to use specific devices to prevent you from not getting exposed. IV tubing, some of them have latex allergy. In this day and age, we really shouldn't have latex issues in the hospital because I think most of our supplies have changed and they are now latex free. But however, if you're working in a smaller community, maybe a nursing home somewhere where they didn't have the resources to invest into purchasing everything that is latex free, then those facilities have what we used to have a long time ago, which is a latex carts. And the latex carts will have everything that is latex free in the carts, including IV access devices and everything you need. But for the most part, everything has become latex free, including gloves that we use before that you used to have latex in them. Biologic hazard, again, when you discard the stuff that you are using, you are exposed to blood. How do you protect yourself when you're starting IV? Keep that in mind. I already talked about facility processes or policies. Um, Now, do you always need to have a personal protective equipment when you start an IV, like a mask, for instance? No, but you will need a gloves when you're starting an IV. Uh, um, you will see nurses sometime after the hand hygiene, they will use their hand to feel the IV. Some will even cut the gloves and remove it from one finger just to use that finger to feel the site. Okay, just know that whenever you're in contact with body secretions, you're supposed to protect yourself. And I'm going to leave that as that. You require training. Again, we have safer equipment these days for IVs. Other things that may potentially cause allergy um, that we used to use, or you can see it sometime in an IV kit, is the iodine swab or the iodine wipe. Right now, most kits have chlorhexidine or you use alcohol. So we're not really using iodine. But however, we use iodine or betadine when we are starting central line. Those are still in those kits. In addition to chlorhexidine, what I've seen is that we use iodine and clean, and then they will use the chlorhexidine. So it depends on what different facilities are using. Sometimes they will use both. Like for surgery, they're still using iodine or betadine swab in surgery before they open surgical incision. It just really depends on the facility and what the update together as a team to use. I talked about latex allergy already, so I'm gonna move on. What are the advantages and disadvantages of IV therapy? Let me start with advantages. Why do we need IV access? We may need an IV access because the patient just need access. We need an access just in case. Let's take a seizure patient who is admitted. One of the seizure safety measure is to have an IV in place if the patient is in the hospital. Because in case they start having intractable seizure, we need to give medication to stop the seizure. So in that case, the access is just in case, right? We may need an IV access for hydration purposes. A patient who is dehydrated or simply need an IV fluid, we may start an IV or have some type of access for that. We may start an IV access for nutrition purposes. And I'm talking about parenteral nutrition like TPN, intralipid, uh, for instance. We may need an IV access for the usual IV medication therapy. And that could be subdivided into a couple of things: regular, piggyback, regular IVs, therapies, or something that we need to give really fast, like IV push, for instance. We may need an IV access um, for electrolyte purposes. Some of the disadvantages of access, and then I'm going to go to the next slide. Okay, talk about this one already. We talk about medication delivery and back to disadvantages. Some of the disadvantages of IV therapy may be, well, mm, if you can give something fast, chances are you can't take it back, right? If you put something in an IV, um, you have constant blood flow, therefore you can't go and take that medication back. So you have to make sure what you're given is what you're given. So that's when the 5 rights or however many rights of medication is going to come in play here, and you're going to make sure that you're giving the dose that you're supposed to give, and you have the proper compatibility and so forth. Um, Another disadvantage of IV therapy is, let's say you're given IV fluid or you're given boluses and you overhydrate the patient. You give more than you need to give, or you give what you're supposed to give, but it was too much for the patient. Then, in that case, the patient is going to have other problems like pulmonary edema and too much being fluid overloaded, where the body will be overwhelmed. How about injury? IV access can have infiltration, or you can have inflammation, or you can have extravasation. This is when the tissue itself, the surrounding tissues, it's not just infected, it's not just full of fluid, like fluid didn't leak from the vein and go to surrounding tissue, but whatever it is that leaked into the vein now has now eroded the tissue and caused some type of necrosis in that place, and that usually will require aggressive wound treatment or sometimes surgical intervention. When you have an IV in the vein, if that IV happened to come out by accident and you have a large bore vein, then the patient may be at risk for bleeds. Now, in addition to that, we can have other problems that we need to be aware of. And some of those are the compatibility issues that we may come across. So you can have compatibility issues because whatever medications or whatever fluids you're given is, or you whatever two things you're mixing together are not compatible. They can be mixed together, or the chemical that are inside the two solution that you're given now react, or one, once the chemical in the two solutions are combined together, the therapeutic effect of one is minimized, for instance. So an example of physical compatibility would be, hmm, it will be something we talk about in neuro, like when we administer Dilantin. Remember, I said Dilantin cannot be administered with dextrose. It has to be administered with NS. When administered with dextrose, the solution will change color. It becomes super cloudy and thick, and it crystallizes. That's physical compatibility issues. When something is changing color and the consistency is completely is changing. As a result, to ensure, since dialantin tend to react with uh, a few things, it's better to start a completely different line. And the fluid that you will need to, the rider, what we call the rider. A rider is when you piggyback something to an IV fluid, the IV fluid that is used to carry that medication is the rider. Those of you who are going to be in the ICU, you're going to have riders for your drips, because sometimes your drip is going at like 3 ml per hour, and you need something to help it move to the patient, because how many 3 ml is it going to take for the whole IV tubing to get to the patient, right? So you will need a rider. So that rider uh, uh, need to be compatible. For Dilantin, that rider is NS. In addition to that, because of the compatibility issue, Dilantin also has to be given when it's being administered. You might have you need to have a filter attached to that tubing, most likely a 5 micron filter. Now, check pharmacy, or you will know your policies on your units, because you have smaller micron filters as well. I believe you have a 2 and a 1.2. Um, Chemical compatibility. What is chemical compatibility? Chemical compatibility will be, again, when you mix two things and there's a chemical reaction, and that chemical reaction produce some type of fume. A chemical compatibility, non-IV related, would be a household cleaning agent. When you mix bleach with ammonia, ammonia product, for instance, you're going to have a really bad reaction. And the fume that is going to come out of that, when you inhale it, you may end up with lung issues, or you may have a respiratory reaction to that. So that's non-drug related. Um, Other chemical compatibility issues, um, again, would be when you give your piggybacking different drugs to your rider. Um, we want to make sure for certain drugs that um, we're using different tubing. Ideally, you're not supposed to use different piggyback for the different meds, but either make sure that the piggyback tubing is clean, that you don't have the other drug, other drugs in the, like say that you're giving vancomycin, and then you have to give Marin. Make sure that the vancomycin is clear completely out of the tubing, so you're not mixing it with the Marin, for instance. You're not mixing it with the cefotaxime, or if at all in doubt for some drug, it's just ideal, like antifungal, and they tend to react to a lot of stuff. It's just best to use a completely different tubing for that. For infectious processes, using different tubing for every antibiotic, it is not recommended, especially when the patient has a central line. We want to minimize that. But for some drugs, you can help it. Whenever you have regular antibiotic and you have an antifungal, chances are you just need a different tubing for those two. That reaction may prevent that drug from working as well. The next compatibility issues that you're going to have will be therapeutic compatibility issues. And therapeutic compatibility issues is when two things are mixed together and one diminish the therapeutic effect of the other, or it maximize the therapeutic effect of the drug. One example that I would give you would be this one is not drug to drug, but it's a good example. We all know that grapefruit cannot be mixed with, okay, those who take Coumadin. It's not ideal for them to eat grapefruit. Why? Because of the way Coumadin clear the body. Drugs, especially that clear through the GI system, the liver, the stomach, you can run into compatibility issues because, especially the stomach, you have other things going there, right? Grapefruit fruit is something we call an inhibitor, which means that it will prevent How does grapefruit cause Coumadin toxicity? It prevents Coumadin from clearing out of the system. As a result, you have too much Coumadin left into this left. You have a lot of Coumadin in the system now. Because you have a lot of Coumadin, the patient is still going to take the next dose, but the Coumadin that they have taken before has not cleared the system. So now the patient is at risk for toxicity. If I were to go from drug to drug therapeutic effect, I can use um, omeprazole. Omeprazole is a drug that we use to decrease stomach acid. If you have drugs that clear through the GI system and they need a stomach acid, omeprazole will cause what? It will cause that drug not to be effective, and that drug is just going to go through the system without being absorbed. So therefore, omeprazole is something we call an inducer. Again, you don't need to know what is an inhibitor or what is an inducer. Those are just terms that I'm using to explain it. So if I'm given omeprazole, I need to make sure that if I'm given a drug that needs that stomach acid, I either have to give it an hour to work before I give my omeprazole. Or I have to know the half-life of my omeprazole. Therefore, I know how long my omeprazole is going to stay in the system and before I give the next dose. That's why sometimes pharmacy will say, don't give this drug with this drug or wait an hour before you give this drug. One drugs that we give, we don't usually mix it, we give it far away, is your Synthroid for thyroid issues. If you notice that drug is given like at 6 o'clock in the morning, well, you give it way before breakfast because it reacts with what? Milk product. You give it way before breakfast or way before the 9 a.m. or the 10 a.m. drug because it reacts with other drugs. Therefore, it might not be effective. Some drug therapeutic effect may be affected. Another drug that I can think of is amiodarone. Amiodarone can affect digoxin. It can affect other drugs. So those drugs probably cannot be given at the same time. Um, drugs that another thing that is not on this slide that I would like to talk about is drug stability problems. Not all drugs are stable, especially when diluted. That's why you notice that some piggyback come already mixed, and some piggyback you have the powder, and when you're ready to give it, you mix it up and you administer it to the patient. A drug that has stability problem that we are giving a lot more now is IV Tylenol. IV Tylenol, you're not going to see pharmacy deliver multiple IV Tylenol already to your floor. They're probably going to give you one or a couple. And if you need more, you will ask for the rest. However, if I am given vancomycin and I need to give 3 doses for the day, all 3 doses may be delivered to me and it will be in the refrigerator because that drug, when diluted, has longer stability. It's very important to check your piggy bag, check the expiration. Usually, when something is premised already or diluted, it only has